I'm Naveen Pereira, Assistant Professor of Medicine at Mayo Clinic, Rochester. And today on Mayo Clinic Talks, we'll be discussing pregnancy and heart disease with my colleague Carole Warnes, who specializes in adult congenital heart disease and has a specific research and clinical interest in heart disease and pregnancy. She was the lead author of the American College of Cardiology and American Heart Association 2008 guidelines for the management of adults with congenital heart disease, and is an integral part of the adult congenital heart disease program at Mayo Clinic, Rochester. Welcome, Carole.
Thank you.
Well, to start off, the way I look at heart disease and pregnancy is two potential scenarios. One is women with pre-existing heart disease who then present in pregnancy, and sometimes women who are pregnant are diagnosed with cardiac disease. So within the framework of these scenarios, Carole, what are the common cardiac diseases that a cardiologist is likely to encounter, and so a general cardiologist needs to focus on these type of issues?
Well, if you think that adult congenital heart disease accounts for 1 million of the population in North America, most maternal cardiovascular disease nowadays is actually congenital in origin. And if you think of the commonality, for example, of bicuspid aortic valve, aortic stenosis is one of the issues that will arise in pregnancy, not uncommonly. We don't see much rheumatic heart disease now, of course, we'll see it occasionally. But the other thing that physicians will see are patients with cardiomyopathies, either ischemic or dilated, and hypertrophic cardiomyopathy even. But congenital heart disease far and away is the most common problem, and so that's why I got involved with an interest in pregnancy. And of course it's a challenge for the cardiologist because the symptoms and signs of a normal pregnancy can mimic cardiac disease, so it's easy to be fooled. But you're right that pregnancy can exacerbate any pre-existing cardiac disease. Ideally, you would have liked a woman to have had a really detailed evaluation before they embark on pregnancy, so there's no surprises. But occasionally, particularly because of the volume load of pregnancy, cardiac disease can manifest for the first time during a pregnancy.
Carole, could you tell us more specifically in your practice what kind of adult congenital heart diseases do you encounter, and when patients with heart disease are pregnant, what are the typical cardiac lesions do they have, for example, prosthetic valves, etc.?
So in our practice, a big tertiary care congenital heart disease program, we see women even with the most complex heart diseases wanting to have a pregnancy. And the good news is that most women with proper care can have a pregnancy. So that's an important thing to underscore. But it may obviously involve the whole spectrum, from women who have small atrial septal defects or ventricular septal defects to someone with the most complex disease, repaired tetralogy of Fallot, single ventricle after Fontans. Prosthetic valves are very important to be managed properly. So patients in all those spectrums, most women, of course, want to have a baby. They want to have a normal life and a family. And so, again, it underscores the importance of a proper, detailed pre-pregnancy evaluation.
For our audience, Carole, could you briefly summarize, and you touched upon this, the important physiological changes that occur in pregnancy that can exacerbate underlying heart disease or result in heart disease?
So the most important thing to consider is the volume load of pregnancy, which begins to go up in the first trimester and then peaks around the middle of the second trimester to about 50% above baseline. So whatever cardiac disease one's dealing with, that ventricle has to withstand that volume load, which is really significant. There's also a fall in afterload which accompanies pregnancy, so the blood pressure tends to go down, and of course the heart rate goes up, the cardiac output goes up, And if you think about those hemodynamic changes, that helps you understand which lesions are better tolerated. So, for example, with the fall in afterload, any stenotic lesion like aortic stenosis will not be as well tolerated because the gradient will go up. Conversely, a regurgitant lesion like mitral regurgitation, although there's a volume load, it's a little bit offset by the afterload reduction. So in general, regurgitant lesions are better tolerated than stenotic ones.
Excellent. Carole, are there certain congenital heart disease patients that you would advise not to consider pregnancy?
Absolutely. The number one on the list are those with pulmonary hypertension, and particularly those with Eisenmenger syndrome. And unfortunately, even in the current era with the modern therapies that we can offer patients, maternal mortality in a lesion like Eisenmenger syndrome is still about 30%. So that's very serious. Other conditions where we are concerned about mother's survival and indeed fetal survival is when the function of the ventricle, be it a systemic right ventricle or a left ventricle, if the ejection fraction in general is less than about 30%, one has to worry about whether the mother's ventricle will tolerate that volume load of pregnancy. Other situations are when the aorta is dilated, for example with Marfan syndrome, or with a bicuspid aortic valve. Of course, the aortopathy goes along with that. And if the aorta is larger than 45 millimeters, we worry that pregnancy will soften the aorta and there's a risk of dissection and rupture. And of course, if a woman has symptomatic obstructive lesions like aortic stenosis before she gets pregnant, that needs to be dealt with before pregnancy is entertained, because it's going to get worse, and we have encountered situations where we even need to perform cardiac surgery during pregnancy or balloon valvotomy. And last but not least, it's not an absolute contraindication, but women with prosthetic valves are a huge issue to manage during pregnancy, and they really need to be counseled appropriately, and if they choose to embark on a pregnancy, really be followed in a tertiary care centre.
That's an excellent summary, Carole, of all the possible contraindications to pregnancy if women do have underlying cardiac disease. And so if we could then move on and ask you as to what kind of advice and you pointed out that a majority of patients could tolerate pregnancy, and in a good tertiary care referral center with cardiologists who are experienced in taking care of these patients, pregnancy can have a successful outcome. But when you talk to the patient, what kind of advice do you give them, starting, say, from prior to conception through delivery?
That pre-pregnancy evaluation is really key. So for congenital heart disease in particular, it falls into two groups broadly. What's the risk to the mother and what's the risk to the baby? So you need a detailed evaluation of the mother, clinical exam obviously, echo, detailed evaluation, and often that should include an exercise test, because patients with congenital heart disease have never known what normal exercise is. And of course, pregnancy is the kind of exercise test, so you want to have an idea of the functional capacity of the mother. And one needs to have a discussion about the risk that pregnancy will impose, potentially, how you should be managed, where you should be managed, where you should be delivered. You need to have a review of what drugs the mother might be on. Should they continue these drugs, or do these drugs pose a risk to the fetus? And from the fetal perspective, what's the risk of my child having congenital heart disease? Can I get through this safely? And for congenital heart disease, of course, that poses a risk for the baby. Do we do a fetal cardiac echo as we're thinking at 24 weeks of pregnancy to assess baby's situation? And are there any genetic conditions that the mother might have that might significantly impact the fetal risk of having congenital heart disease? And there needs to be a discussion about the mother's prognosis in general. One thing that's not often thought about is the mother is often very driven to have one pregnancy. But not just can I get through the pregnancy, but is it possible this volume load of pregnancy might distort the hemodynamics, might make an AV valve more regurgitant, and so that the mother might not go back to baseline even after a successful delivery. So we need to think about, is there a potential negative impact on mother's baseline hemodynamics? And last but not least, an important discussion about maternal prognosis. What's the life expectancy? And for complex patients with single ventricle transposition of the great arteries, are they going to be living another decade or two to see their child go off to college? That's a difficult and sensitive discussion, but it needs to be had.
So really, patients should have a comprehensive evaluation before contemplating pregnancy, and they need to be guided very carefully through the process. And so that leads me to ask you, Carole, when a general cardiologist encounters such a patient who's contemplating pregnancy, when should that cardiologist consider referring these patients to a specialized program that deals with adult congenital heart disease?
So for simple lesions, things like a repaired ductus, a very small VSD with no valvular consequences, a repaired atrial septal defect, those simple lesions, I think, can be handled by a cardiologist as long as they're comfortable with managing them through pregnancy. Mild pulmonary stenosis would be another example. But I think for other lesions where there may be residua of surgery the cardiologist might not be aware of, they might not be familiar with some of the congenital heart lesions or valvular stenosis, cardiomyopathy, for example. If there's any doubt at all, I think patients should be referred to special centres because, this is a difficult time. This is the one time when there is potential for maternal mortality and fetal mortality. So if there is any doubt, and this is in accordance with both the American College of Cardiology guidelines and indeed the more recently published European guidelines, for any other lesions, then those patients should be seen first.
So if the cardiologist does take upon him or herself to manage these patients, Carole, can you briefly touch upon the cardiac drugs that are absolutely contraindicated in pregnancy and perhaps should be discontinued? Most drugs don't fall into a safe category, but some are absolutely contraindicated.
Yeah, so the ones that are really problematic are ACE inhibitors and ARBs. Statins are contraindicated during pregnancy. They're the number ones. Fortunately, most of the other cardiac drugs can be utilized. We obviously have to weigh up the risks and the benefits for the mother, but they're really the top three. There are obviously particular concerns about Coumadin, and that requires a very special discussion, particularly in the context of patients being managed with mechanical prosthetic valves.
Can you expand on that, Carole? How do you manage these patients with mechanical prosthetic valves?
So the important thing first is that patients need to be individualized. The discussion generally involves around, again, a complete assessment. Is the valve working normally? What's the patient's cardiac function and so on? But then the decision will come, assuming all that is worked through, is how to manage the anticoagulation issue through pregnancy. The most difficult valve, the most problematic, is the mechanical mitral valve, particularly the tilting disc valve, and the choices of anticoagulant strategy, which are essentially either Coumadin throughout pregnancy, resorting to heparin, either unfractionated heparin or low molecular weight heparin in the first trimester, then back to Coumadin, and then heparin pre-delivery, or some will consider heparin throughout the pregnancy. So they're the three strategies. The problem is that pregnancy is the most prothrombotic state that one can have. It's not like managing non-cardiac surgery. And heparin is not such a good anticoagulant as Coumadin. So one has to have the discussion, am I going to accept some risk of embryopathy if I take Coumadin in the first trimester, or throughout pregnancy, or am I going to switch to heparin? And much has been written about that recently. I think briefly one would say the risk of Coumadin embryopathy has been somewhat overstated. The risk is probably less than 6%. And importantly, the risk to the baby is dose-related. And that risk is very, very small if the mother is on less than 5 milligrams of Coumadin a day. And so one has to have that discussion, an individualized approach based on what the mother wants and what physicians want to do. One common mistake, though, I would highlight is the assumption that we'll just switch you to low molecular weight heparin and all will be well. And in fact, if you look at all the data that's been published in recent years on low molecular weight heparin and prosthetic valves, the risk of maternal thrombosis on a prosthetic valve, not even thromboembolism, is as high as 17% with low molecular weight heparin. So this is why women really need to be managed in special centres with all of the discussion about what's best for them. And low molecular weight heparin is not a straightforward and easy solution, even with meticulous monitoring of anti-10A.
That's wonderful and useful information, Carole. A question often comes up as to how do you advise the treating obstetrician as to whether a woman who's pregnant should be delivered by natural means, vaginal delivery versus cesarean section? How do you make that decision, Carole, for a specific patient?
Well, there's another common mistake is that women with heart disease all have to be delivered by cesarean section. That actually isn't true. In fact, the blood loss from a cesarean section is higher than with a vaginal delivery. So most women can deliver safely vaginally. Having said that, one likes the labour to be relatively short so that they're not in labour for 24, 36, 48 hours because of the hemodynamic changes that happen very abruptly during labour and delivery. So most women can anticipate a vaginal delivery unless there's an obstetric reason. Having said that, there are certain indications for cesarean section. For example, a dilated aorta, where one wouldn't want a woman valsalvaring, essentially pushing in labour for long periods of time. Probably with pulmonary hypertension, so that you have cardiac obstetric anesthesia, the whole team there for a very short period of hemodynamic perturbation, often to try and save the life of the mother. And aortic stenosis would be another example, stenotic lesions where the woman is decompensated. Having said that, for issues like complex congenital heart disease, often the mother might not tolerate going to 40 weeks of term, and we need to get the baby out earlier. Aortic stenosis would be another example of that. And so if the mother's cervix isn't ready, we might need to do a cesarean section to, if necessary, get the baby out to minimize the hemodynamic perturbations on the mother if she's starting to decompensate.
Excellent, Carole. Finally, a few words perhaps on peripartum cardiomyopathy. Do you use bromocriptine in patients who have developed cardiomyopathy? A lot of these patients recover LV function spontaneously. There's no good prospective data on the issue. But what do you personally do? And a difficult issue is, how do you advise these patients? And a lot of them want to have a second pregnancy. How do you go about that decision making?
This is always a difficult question because, of course, about 20 to 40% of women will normalize their ventricular function after the first episode of peripartum cardiomyopathy. And so that's an important question that comes up. If they do normalize their ejection fraction, they have to recognize, though, that there is still a significant chance of getting peripartum cardiomyopathy the second time around. And that varies perhaps on patients and perhaps the country that they're in, but it's at least a recurrence of 20%. And the problem with that is if the ejection fraction goes down again with a second pregnancy, it may go down and stay down. And from most data that we know, the ejection fraction often goes down by another 20%, and it may stay there. And if the ejection fraction hasn't normalized after the first pregnancy, let's say it's 45%, and then they embark on a second pregnancy, there is a definite risk of mortality. In fact, there is published data from one small retrospective series that said that maternal mortality might be about 19% in those women who had not normalized their ejection fraction after the first bout of peripartum cardiomyopathy. So it's a really important question, and my advice usually is don't have another pregnancy. If you've got a healthy baby now and you got through what can be a potentially catastrophic situation with impaired ventricular function, VT, pulmonary edema, don't risk it, because even if your ventricular function is normalized, the risk of mortality with a second pregnancy may be very low, but there is a significant risk of permanently impairing your ventricular function the next time around. And if you've got a healthy baby, you want to be around for hopefully 20 years at least to see that child growing up. In terms of the bromocriptine story, it's an interesting story and a fascinating one. Of course, it's preventing the prolactin toxicity, if you will, that we now know is probably implicated in the development of this interesting condition. I'm not sure that it's ready for prime time yet. There is very interesting animal data and small data, particularly from Karen Sliwa and her group. We have concerns about the thrombotic implications with bromocriptine. I think we will have more data there within the next few years, and it may be that it comes more into routine clinical practice when we have more data, but certainly very promising.
So you don't use it in your practice, Carole, routinely?
We have done. We've used it once or twice in recent cases, but I think to say that we should use it routinely, I think we're not there yet.
Okay. Carole, I could go on. You're such a fountain of knowledge. Thank you so much for these valuable and great insights. I learned a lot. And thank you, our listeners, for tuning in to Mayo Clinic Talks.
Thank you.